Well, since we're going to talk about rhythm control, let's talk about our drug choices. And let me just, in no particular order, talk about the drug. So you have a drug like dofetilide. Dofetilide can markedly prolong the QT interval in some patients. This is the reason it's mandated to start in the hospital. There's a lot of literature on all these drugs, so I've treated hundreds of people with drugs for AFib. I'm going to give you some of my own personal experiences. Dofetilide has a unique property for me when I have a patient who has a slow heart rate when they're in normal rhythm. Most of the other antiarrhythmic drugs kind of pile on because their ionic effects also affect the sinus node. So it gets slower and slower, and you get in the issue, should I need a pacemaker now to keep the heart rate up? Dofetilide doesn't do it that much, so it's one of the drugs that I use to try to get out of that conundrum. It also has a wonderful ability to actually cardiovert the patient. In our experience, 40 to 50% of people will be spontaneously cardioverted, and you can avoid direct shock cardioversion. But you have to watch for drug-drug interactions. That's a big thing. I like to use that drug when I'm looking to get cardioverted patient, when I have a patient with a slow sinus rate. They can't have a thick ventricle, but they can have coronary disease and they can have even heart failure. So that's a drug that I sort of look at in that situation. Sotalol is another common drug I use. It's both a beta blocker and an antiarrhythmic. And at the lower doses, there tends to be a little more beta blocker effect. So if you have somebody whose heart rate's 45 to 50 when you're in normal rhythm, I'm just telling you, you're not going to get away with sotalol. Because if you give sotalol, now they're going to be 35 to 40 beats a minute, and they're just not going to feel good. Now, maybe you could add a pacemaker, that's a Brady-Tachy syndrome, and now you can advance the dose. The problem is, you use too little of it, it doesn't work, and then you say, oh, the drugs don't work. Well, drug isn't working because you didn't use the appropriate dose. But I get it. But if a person has reasonable sinus rates and they have a normal heart, I often will start it as an outpatient if they're not in atrial fib. I know that some people don't like to do that, so if you don't, you can start it in the hospital. But I don't start it as an outpatient as 120 milligrams twice a day. I start low, like 80 milligrams twice a day. I either have them come back for an ECG, or I have them send me in rhythm strips. If they do fine and they're doing, they're keeping a normal rhythm, I stop. If not, I might up the dose. Dronedarone is an interesting drug in my experience. It's safe to use as an outpatient in multiple situations, not heart failure, but I've used it in coronary disease. It's an interesting drug because for me it's like a yes or no drug. I do not know why this is so, but in my own experience it either has a remarkable ability to suppress someone's AFib, or it does almost nothing. And usually figure that out within the first week or two of using the drug. Patient will call and say, nothing's happening, Dr. P, and I say, okay, we'll switch to something else. Or I'll call them, or they'll call me and say, wow, I don't have any more episodes. I'm not exactly sure where that happens, but at least in my experience, it's almost like a switch. It either works or it doesn't work. Then you have the drugs like flecainide and propafenone. They're kind of similar in my experience. They're excellent drugs. I use them mostly in patients who have, almost in fact exclusively in patients who have normal hearts. I also want to make sure those patients have a beta blocker or a calcium channel blocker so they don't go real fast if they go in atrial fib or flutter. But they're safe to start as an outpatient if you're in normal rhythm. They don't have a lot of drug-drug interactions, and they're quite successful. And I sometimes will start flecainide even at low doses, at 50 milligrams twice a day. It's amazing to see how some people are so sensitive to the drug that you can get away with a really low dose. Last of all, you have amiodarone. So amiodarone is the kingpin of drugs and in the fact of effectiveness. It's also the kingpin in side effects. So amiodarone has multiple ways it can affect atrial fib. It affects a lot of different channels in the heart. It's extremely effective. It can be started safely as an outpatient in almost any situation. The downside of amiodarone, it does have a lot of drug-drug interactions. You have to check what else patients are on, warfarin, certain statins. You got to be aware of that. And it can have a 3 to 5% chance of causing toxicity to the lungs, liver, and thyroid. So you can see you have a lot of choices. You got to know the drugs, you got to know the patient, you got to know the doses, but you can usually, with a little time and effort with each patient, pick the best 1-2 punch for that patient. And if that's not working, in my experience, if you fail a couple drugs, you might as well go on to ablation, unless you haven't tried amio. If you fail 1 or 2 of the non-amio drugs, my experience has been the third one's not going to work, and either go amiodarone or ablation. But don't forget, ablation could also be used as an upfront therapy.